online very much informs the conversations I'll be having with you today. Someone's written in a comment here, a question, and I'll just read it to you all and ponder it before I move on. And I really encourage you to write questions like this. This is Angela, who says, could I speak about shame and stigma through the lens of spirituality, or is that beyond the scope of this program? It's a very good question. There's a couple of ways I want to answer that for now, Angela. And one thought is that I view what we'll be talking about today, I do view it through a spiritual lens. In fact, for you to know, Angela and others, I've always had this feeling about psychology. My training is as a clinical psychologist, and most of what I've done across my career is under the umbrella of psychotherapy. I've always had this strong conviction that psychotherapy or counseling is the handmaiden of spirituality, which is to say that it's in service of opening the door to authentic, healthful spirituality. And so there's a way, even if I use psychological terminology today, that the basis for me is I believe it's in support of the human spirit. So that's absolutely true for me as I'm speaking today. That's an implicit understanding about the lens through which I'll be speaking today. More explicitly, we'll see how it goes today in our conversation. I decided just this morning that if we have time towards the end, I'd like to introduce an exercise that is more explicitly, at least inviting of spirituality and a spiritual perspective on what we'll be talking about as we look at shame and stigma, specifically unshaming. How do we reduce shame? And so if we have time, I'd like to introduce an exercise that is quite explicitly not only psychological, but spiritual in intent. So let's see how that goes. So for sure, what we'll be talking about, you can already tell by the way I've introduced this topic, talking about individuals in recovery from addiction, is that the wish is to convey an honoring and a respect for individuals who suffer. And as we'll be speaking in just a few minutes about stigma, for example, individuals who suffer oftentimes with a tremendous amount of judgment societally. And so I think it mandates a spiritual response, and that will be implicit throughout the presentation. I hope that that gives you some sense of the spirit in which we're speaking today, as well as hope that maybe towards the end we might make that even more explicit. Thank you for the question. Well, I've already said it. The topic for today is unshaming. As far as I know, that's a word that came to me. I don't know that I invented it. It came to me in my reflection over the last 3 years. I've been working on a book. It's nearing completion. I'm in the editing phase of the book, and that's the title of the book, Unshaming. I'm well aware that that's really not a normal word. I don't know that anybody uses that word typically, but I think it conveys in a single word what it is that we're aiming at today. And it's interesting to me. More recently, in groups that I lead in local treatment centers, I lead groups in I think 5 different treatment centers right now, is that the clinical directors will ask me, what would you like to call the group? And I say, well, how about unshaming? And so that's actually the term that's used for the groups I lead right now, which is interesting to me because it's not a technical term, and it actually communicates not only to the clients that I'm working with, but the staff that work with them. It's like, okay, that's what Dr. Bob does. He leads unshaming groups. And so we're going to have an unshaming group here today, okay? And the context of that, or the spirit behind that, is that I see, and I hope by the end of today's dialogue here, that you will see as well, that unshaming is absolutely core or essential to sustained, successful recovery. And we'll be speaking about recovery from addiction to alcohol and other drugs. I don't want to exclude the possibility that you may personally be applying this or be interested professionally applying this to addiction to other behaviors. There are any number of behavioral addictions that most of us have some firsthand experience with that may not be to substance, but have the same dynamics and actually utilize the same brain circuitry as addiction to alcohol and other drugs. And so while I'll be focusing on addiction to substances, I don't believe that what we talk about today is limited to that conversation. And so I want to invite you. In fact, let me say a word about this. If you yourself are in recovery from addiction, or even contemplating recovery from addiction, this presentation is intended for you. If you are a loved one of someone who is currently addicted and hopefully open to seeking healing from addiction, I believe this presentation is apt for you as well. And then finally, if you are a healthcare provider providing services to either of the two previous groups, those that are in recovery from addiction or the loved ones of those in recovery from addiction, I hope that you'll find this to be pertinent to your work as well. So that's the wish. Let me underscore one final thing before we dive in, and that is something that Anna emphasized. I really welcome the dialogue. Already some of you began to write to me, and I'll do the best I can to track that as we're speaking. And what I'll do is I'll do my best to weave in your questions into the material. And as I shared with Anna earlier, if it turns out that you ask a question that I hope to address in 5 minutes from now, working off this PowerPoint slide is somewhat organized, I'll just say that. Hang on to that question. We'll come back to it in 5 minutes. And I'll do my best to answer your questions and weave them in organically into the entire presentation. So fully inviting dialogue with you all. In fact, in my years of teaching live in a classroom setting, now the work I do as a professor is online. But in my days of teaching in classroom, in the syllabus, I would refer to my lectures. Over time, I referred to them as lecture/dialogue. The idea being is that the contributions from students in my classes was key to the material. And I believe that very strongly today. So I encourage you to join me in conversation as we move forward. And thank you for being here. So let's start with a few statistics. These are important statistics. Just a second here. Here we go. Here's the first statistic. You may or may not be aware of this, that 1 out of 4 adults in the U.S. is currently addicted to substance. And this is limited to alcohol, nicotine, and other psychoactive drugs. These are drugs that directly affect brain function. And so 1 out of 4 adults. And if I'm not mistaken, that statistic is even more sobering, no pun intended here at all, is that statistic is 1 out of 4 individuals 12 years old or older are currently addicted. And if that seems shocking to you, it may not. I want to verify that in the work that I do, most of the clients I work with, for example, in the treatment center setting, began using before they were adolescents. So 11, 12, maybe 13 years of age. Most of the clients were already addicted to, oftentimes start with alcohol or with marijuana and move from there. And so that's 25% of the American population. These statistics can be bracing, but I'm not sharing it with you just to make you depressed. What I want to do is I want to open up the possibility that we can look at the prevalence of addiction and begin to have, hopefully, more of a sense of the emergency involved, but also the sense of how many lives it touches. In fact, the next statistic will open that up even further. 2/3 of us have a family member who is currently addicted. 2/3 of us. That makes it universal. That makes it universal. And if you don't have a family member addicted, chances are you have a friend or a relative or somebody at work that is addicted. So it's universal. The next statistic gets us into the topic of the day. In the same study that looked at the prevalence of addiction in our families, it was discovered that 2/3 of us are too ashamed to share with anyone outside of our immediate family that we have addiction in our family. So if we have addiction in our family, we're not talking about it. Now, you might ask at this point, you might not, but I'm going to ask, why won't we share? Why are we too ashamed to share? I think the next finding will help open up some thought about that. Johns Hopkins School of Public Health, one of the premier schools of public health in the world, recently did a study, and what they utilized was the Diagnostic and Statistical Manual of Psychology and Psychiatry, and that in the DSM, there are all these diagnoses from depression and anxiety to personality disorders to psychotic disorders and so on. And what they discovered is that there's significantly more stigma, negative attributions made towards addicted individuals than any other mental illness. So you begin to get a sense of why, if at a societal level there's this negative judgment where being addicted is at the very bottom of the barrel of any source of mental or emotional suffering, why we might be disinclined to share that with others. I want to pause for a second. Someone added here about the prior statistic where I suggested that 1 out of 4 adults is currently addicted to substance. This person said they're assuming that caffeine, which is a psychoactive stimulant, is serving to drive those statistics up. Actually, caffeine was excluded from that statistic. I don't quote me on this, but I think it's something like this. I recently read that up to 80% of Americans drink caffeine on a daily basis. It's virtually universal. And this particular study that I'm mentioning from the National Institute on Drug Abuse, they excluded caffeine because it would have artificially inflated those statistics. And so this is partialing out caffeine, just for you to know. And it's not to say that everybody who drinks caffeine is addicted, in order to say everybody that drinks alcohol is addicted. I certainly have had clients that exhibited symptoms of what's referred to as hypercaffeinism, which would be drinking quarts of coffee each day until they experience just a generalized anxiety that doesn't let up. It's directly a function of what this gentleman Arnold shared, which is that it's a psychoactive stimulant. So we've removed caffeine from that formula, from that study. Thanks for clarifying that. I appreciate that. Back to this idea then of stigma towards addicted individuals. What I want to ask you to do, and we'll do this 2 or 3 more times today, is I want you to join me in a journal exercise. And so if you have a piece of paper and a pen, I would like you to utilize that right now. You may be at a computer or at a tablet. You're welcome to utilize that too. I'll be grounding theory and research and other conversations about addiction recovery. I'll be grounding them in exercises today. And I want to tell you why. It'll become clearer as we talk in the next segment that what we're talking about has such personal impact for each one of us. And that we can, if we can find a way to take these concepts that are otherwise very abstract and find ways to locate them inside our own experience, either personally with addiction or relationally with addiction, I think what it will do is it will lend it'll lend a sense of gravity to what we're talking about, as well as make it real for each of us individually, as well as I'm hoping one of the intentions of this is to encourage our own compassion. So I want to move it from just talking about words and concepts into that plus feeling into our own experiences. So my first question for this first journal exercise, and I'll allow just a minute or so for you to write, because I do want you to write and reflect on this. And then I want to ask you to be, for those of you who are willing to share what you came up with, I'd like to share some examples if that's okay. I'm not going to be putting anybody on the spot here, okay? I would like to ask you to consider for just a moment how have you experienced stigma towards addiction in your own life? It could be that you've struggled with addiction yourself and been on the receiving end directly of negative societal judgments. It could be that you've experienced in yourself, for example, a loved one being addicted and felt judgment towards them, and oftentimes very understandably. There's so much hurt and disappointment and fear associated with having a loved one addicted that it will manifest not infrequently as anger and blaming. So that'd be an example. And if you're in the healthcare professions that provide services to those that have struggled or are struggling with addiction, how have you seen stigma, perhaps even inside the mental health professions or the healthcare professions around addiction recovery? So just write out a few thoughts here. I'll invite any of you to share that are willing to, and I'll be selective in terms of bringing those to the group. So this is the first chance that we have to interact together. So let's take a minute here just to get our thoughts down on paper. Thank you. Several of you have written in comments. Let me review these comments. Give me just a moment to review these comments, and I'll incorporate them into our conversation then. Thank you all for sharing, and I'll weave in some of the comments. I believe that these are visible to all, so I don't believe that there's any problem naming individuals. Okay, I think everyone can see who's shared so far. I think I want to respond to Gabrielle's comment, who shares that in working with her patients, that family members will express stigma towards the family member, correlating that addiction with weakness. I think that you've touched on a very powerful theme here in terms of stigma, is that we can spend a lot of time talking about the publicity that we're aware of through advertising and so on, that equates addiction with being an aberration, a weakness, a defect in the individual, and we'll be talking more about that later in terms of how do we separate that all out. But it's oftentimes correlated with weakness. One of the things, Gabrielle and others, that's come up for me recently in my work is this kind of being caught in between a rock and a hard place that can be the experience of an individual early in recovery, is that they will have experienced judgment from family members and from society for being weak owing to the identified addiction. And then ironically, but in some ways just as painfully, they will have experienced judgment from those with whom they engaged in addictive behaviors, because the admission of addiction is seen as a weakness even to that group. So to admit to one's drinking buddies that one has a problem with drinking is judged by those drinking buddies as weakness, just as the larger society and perhaps family members might judge that individual for having become addicted to alcohol too. And so it's really kind of a no-win situation. No matter where you turn, it's a catch-22. So I think there's a lot of equation of addiction with something wrong with the individual, including being weak. Let me check a couple more comments have come in here. Yeah. Appreciate all of your input here. Yeah. I encourage all of you to read those comments that are coming in. I believe that you can see them. I'm going to pick one that was shared here with Emily from a guest viewing in Emily's office. The pain that can be had of letting oneself down. I cited the statistic earlier that 2/3 of us have a family member who is addicted. Letting ourselves down, and then on top of that, fearing that we're modeling for others the very behaviors that would be the least likely, that we'd want least for them to model after, namely addictive behaviors. And so the pain and the self judgment that come from letting ourselves down and then letting others down. I should mention this is that the term that we'll be moving into talking about shame momentarily. The stigma is a negative judgment that's coming from others. One of the terms that psychology uses for shame is simply self-stigmatization, where I internalize the shame or the stigma that would come from others. I internalize that and aim that stigma at myself, and that equates with shame. And so there were several comments that touched on the disappointment and the sadness, the sorrow. Psychology refers to these emotions as primary emotions: to feel sad, to feel afraid. For example, what parent wouldn't be scared to death if they saw their child becoming addicted or actively addicted to substance? Especially if it's life-threatening. And yet, what will oftentimes happen, including in our families, is that we'll move from that primary emotion of fear for our child's life and deep grief or sadness. We'll move to a secondary emotion, and that secondary emotion oftentimes will be of judgment and blaming. And so it's not infrequent that stigma, whether it happens within families or within society, comes from a place of helplessness. And rather than feel helpless, let me just be mad. So we're getting into the emotions that surround stigma, both in terms of being on the receiving end as well as being the one who might have those attitudes. Thank you all for your contributions here. And let me continue on. Every one of these is valuable. We could spend the entire remainder of our time talking into them. Thank you. We'll have a few more exercises. Will I encourage this kind of engagement? Really appreciate it. Let me shift the conversation here in the spirit that some of you have shared personally. Let me shift this to being a bit more personal with you all. First of all, let me cite a statistic that you may not be aware of. The Substance Abuse and Mental Health Administration out of Washington, sometimes referred to as SAMHSA, recently released a study in which they found that up to 1 out of 2 therapy clients, people coming into therapy to see a psychologist, a marriage and family therapist, a social worker, up to 1 out of 2 of those are currently addicted. I've been in practice for over 30 years, and I can verify that that's the case. I also want to add this, which is that most clients coming in who are dealing with addiction don't come in saying that that's why they're coming to see you. Some do. But we've already established why you wouldn't want to talk about addiction with this kind of stigma, for one thing, much less the self-judgment that's going on. So clients will come in more typically, in my experience clinically, and I've compared notes with other clinicians who've been at this work for a long time as well, is that clients will come in talking about a work problem or a marriage problem in a relationship, or maybe a parenting issue. And what will come out over time is an admission that I'm addicted to alcohol, I'm addicted to marijuana, I'm addicted to cocaine. It will come out later. And I want to say this, I cite the statistics, I want to suggest this, is that most therapists I know, and I'm going to speak of myself, having practiced for decades, that as I dealt with clients coming to me that were eventually admitting to me that they were addicted and wanted to address the addiction as part of the therapy, I was never an individual who typically behaved judgmentally. I didn't feel judgmental towards these clients. In fact, I felt admiring of their courage. But all of that changed for me, and I want to share with you how all of that changed for me suddenly. You've heard this phrase before, physician, heal thyself. It was in midlife for me that I became addicted to alcohol. It started off, I suppose you might say, innocently enough, but I went down a rabbit hole over a period of years with alcohol, and then eventually introduced other recreational drugs, really for the first time in my life. I had not engaged in drinking or drugging, as you might see more typically in adolescence. That waited till midlife for me. And then eventually got myself, in addition to that, addicted to prescription medication. So it was just a disaster for me in midlife. And this is after practicing for decades as a psychologist. In the process of becoming addicted and then at some point hitting bottom and being aware that I was going to have to address this, I was faced for the first time with what I had missed my entire career, which is, even though I did not feel like I was explicitly judgmental about addiction, and you may not feel this way yourself, depends on your experience and who you are, what I discovered was how that there were subtle levels of judgment. And it went more like this for me, is that I'm not one of those until I was, and I am. And that's made all the difference for me in terms of what we'll be talking about today, because I'm not talking primarily out of theory, out of abstract ideas. I'm talking out of personal experience. In fact, there's an ironic piece I want to share with you. When I was an undergraduate, I was a double major in undergraduate university in psychology and religious studies. And then I went to graduate school and I was a double major there. I got my master's in psychology and my doctorate in psychology. I also got a master's in religious study. You already know that. Well, along the way, I read this book. This was in, I think, my senior year of college, nearly 40 years ago. I read this book by a pastoral theologian, Henry Nouwen. The book was called The Wounded Healer. I was deeply touched by this book all those years ago in my early 20s. And I do think it's ironic and even somewhat prophetic that that book actually laid the groundwork for my experience of the last 10 years, which is very much operating from a position of wounds that I had never experienced before, and now I understand from the inside. And some of you will be able to relate to this yourselves. If you've been close to addiction, if you know it yourself personally, there's a way it's no longer at arm's length. In fact, the clients that I work with here locally and internationally, that's one of the pieces that they comment on, is that it's clear that I'm not talking out of a book, and I'm transparent with my clients as I am with you right now. Most of what I've learned about addiction and recovery, and certainly today's topic, shame, comes from the inside. I have to tell you something, is that when I was in graduate school, we studied shame We studied all the unpleasant emotions. I've already shared with you that we psychologists get a lot of training in emotional life as well as relationships and how those two intersect with each other. One of the things that I discovered, again, this was reading in a book, and I'm going to share this more personally in a moment. One of the things I discovered in studying shame is that of all the negative or unpleasant human emotions, shame is the most stressful of all. The way this has been verified is that there are literally hundreds of studies that have looked at what emotions stir the highest release of this stress hormone, cortisol. The two stress hormones, adrenaline and cortisol, are associated with anxiety or stress, and consistently the emotions that center around this phenomenon of shame are associated with the highest release of cortisol, which is to say, these are the most stressful emotions. Before I go any further, though, we better define shame. And I have to tell you that I learned how to define shame in graduate school out of books. This is, again, before I had really experienced. In fact, if you had met me in graduate school as I was studying shame, writing papers about shame, I probably would have told you that I didn't really know shame firsthand. Certainly not the kind of shame that came from me, as I shared with just moments ago, the kind of shame that came to me at midlife. So here's how psychology defines shame. Shame represents a response to one of two threats. In fact, they're intertwined, hence that double-facing arrow. Threats to social acceptance on the one hand, and threats to self-esteem on the other. In fact, I like to think of these as two sides of a coin. Well, so let's talk about that for just a moment, the way that Bob Weathers learned about shame in graduate school, and then we're going to move into more personal application of this material. Why would it be that if we're not accepted by somebody, that is, if we're rejected by somebody, why would it be that that would be so connected to this elevation in cortisol, which is to say, this elevation in stress? When I ask this question of clients that I work with, they can typically answer quickly by saying, well, we rely on each other biologically. Down through human evolution, those that have been able to stay connected to their clan, to their people, to their tribe, to their family, those are the ones that survive. And there's a lot of truth to that. Well, if that's the case, how would that be connected to self-esteem? Well, think about it this way, that if I am not capable of having my family or my tribe accept me, if they kick me out, making me more vulnerable to predators, for example, then I'm not really successful at something that's absolutely imperative for my survival. And how am I going to feel about that? Well, the answer would be not good. Psychology talks about self-esteem this way, is the way that we build self-esteem is by what's referred to as self-efficacy, being effective at doing what it is that we need to do. And just in terms of the very basic level of physical survival, if I can't successfully pull that off by staying connected to you, then my self-esteem takes a major, major blow. So my way of understanding this is that self-esteem and social acceptance are intimately tied to each other. But before we go any further, I just want to ask you to engage in the second exercise. I'm going to ask you to do this. Can you think of a time where you experienced one or both of these threats together? I'm going to back up for a second. The threats being, can you think of a time where you were kicked out, rejected by people, especially people that mattered to you? And can you reflect on what that felt like in terms of your sense of self? How did that feel to you in terms of your self-esteem? I want to allow for a minute for you to reflect on this, please. Write down some notes, and I'm happy again for you to share your thoughts, and I'll discuss as many as I can. Okay. Uh, what I'd like to do is I'd like to invite you to share, if you're willing, any element of an experience you've had of this kind of double exposure to these two threats. And what I've done while we've been sitting here is reflecting on how that went for me, and also went back and reviewed what somebody had shared just earlier. In fact, Deborah, it's you, and I think you've just shared something else here. Let me read what you just wrote. Thank you. I was struck, Deborah, by what you shared earlier about your kids referring to you as a crackhead, and now you give an example of what it was like to grow up not being accepted, apparently by your mother, and being compared unfavorably to your sister, and that even in addiction, or maybe especially in addiction, that you were rejected by your mother, and that this experience of her being ashamed of you, and how wounding that is to any of us, how wounding that was to you, is that it's impossible to separate, isn't it, in this spirit of being not accepted by, in this case, your mother, on the one hand, and how that felt to you, which would be completely rejected, and perhaps even hopeless and rejected of yourself. I'm going to scroll back up here. Angela, you shared, I wanted to crawl into a hole, and at the same time I was terrified I could not take care of my basic needs as I had lost my job. Whether it's losing a family member's support and trust in us, or losing employment, losing a job, it's terrifying. It's terrifying, and you named it well, Angela. And then how that can go into self-doubt in a profound way that adds fuel to the fire, makes it even harder to connect with others, makes it even harder to find a new job when I'm feeling so bad about myself. Yeah. For anybody that's dealt with addiction directly, or for that matter, indirectly, you'll know this experience of being, I mentioned it earlier, of being rejected not only by the larger society and very likely family members. In fact, I have to say this when I'm leading groups here locally, and I'll ask individuals who are willing to raise their hand if they've experienced at least one loved one giving up on them. That is, just giving up completely. I'm done with you. That kind of giving up. And it's virtually every time I ask that question, every single person raises their hand, is that they've been given up on. And so you want to talk about a threat to social acceptance. It's universal in the context of addiction. And then as we began applying that in these conversations there as well as today, you can imagine what that feels like. Those that would have loved you in the past, or ideally would have loved you in the past, rejecting you and in fact giving up hope. How can you possibly feel about that other than just absolutely awful to the extreme? I've already implied this, and so let me ask a question here. Let me move forward here. How does what we're talking about here in terms of shame and these twin aspects, how does this relate to addiction? Magash is going to talk about it not only as, because we can talk about examples as a function of addiction, I was rejected. I'd like to think about this for a moment together with you all as the origins as well of addiction. So you could say it's the origin and the consequence of addiction. And it's implied in what Deborah shared here. I really appreciate your courage, Deborah, to share with us what it's like to grow up in an environment where you've not been accepted, how that can set the groundwork for a later addiction. I want to explain how that can happen. So let's talk first of all about triggers for relapse. I ask clients, what's the number one trigger for relapse? The research is clear in indicating the number one trigger for relapse is stress. We already talked about elevations in cortisol. So when the cortisol goes up, relapse goes up. Now, stress can be defined very differently for different individuals. In fact, when I ask individuals to share with me what they find stressful, I'll get a range of responses. That can include relationship problems. That can include financial stressors. Oftentimes I'll have somebody talk about boredom, that they find boredom most stressful. So the umbrella term is stress, and underneath that are all the individual experiences and vulnerabilities that we have to stress. I think somebody has their mic off, and so if you can mute that mic, okay, it's just making a noise there. Thank you. So if the number one stressor, the number one trigger for relapse is stress, let's talk a little bit more about how that goes in the body and in the brain. Think about it this way in terms of triggers. If I'm experiencing internal stress for any of the reasons that you can imagine that you might be stressed, and those stressors become to be associated with external cues. So for example, if I have a stressful marriage, that my spouse's presence is a cue or a trigger for internal stress, it begins to be an automatic connection to that. If it's about finances or about a job, all of these external events end up cueing internal stress. And we've already established that what is the number one most stressful emotion as an internal stressor? It's shame. So you sometimes don't even need an external cue particularly. Shame can well up on its own. And then certainly if you've experienced shame in the context of relationships, such as the examples that have been given here, then those relationships cue up the internal stress. So how do we respond to that? There's what's referred to in psychology and in addiction theory as the self-medication hypothesis, and it's pretty much what it sounds like, is that for many of us, vulnerability to addictive behaviors, whether it's the substance or other so-called process addictions, is in response to the unpleasantness of stress. And if we find a way to medicate, that is, lower the experience of stress, literally lower the cortisol level, that's exactly what we're aiming for. And then you begin to see the logic of how it is that stress is connected to addiction. Let me talk about it more technically for just a moment. I promise you just this one slide. If what we want to do is banish cortisol, that is that middle stress hormone in there, if we want to draw a line through cortisol, then one of the brain neurotransmitters, a chemical in the brain that's associated with the lowering of cortisol, is dopamine. You see that at the top there. So if I can find an experience that elevates dopamine, it will lower cortisol, and that's cash in the bank in terms of self-medication. Now there's a cycle that gets going here in the brain, and it goes like this, is that certain experiences, for example, substances, which will double or triple or quadruple or even more so our normal dopamine levels, our brain remembers those dopamine elevators with another chemical referred to as glutamate. Glutamate locks in our memory of that particular dopamine-producing substance or behavior. And so you get a cycle, and this is really how you understand the cycle of triggering, is that if I've got raised stress, I want to reduce the stress, I want to reduce the cortisol, let me find what worked before. What worked before was something associated with a large release of dopamine in my brain. So whether it was cocaine or gambling or eating or shopping or porn, any one of these can serve in terms of elevation of dopamine. My brain automatically remembers that, and it's a little bit like a knee-jerk reflex. It's automatic going towards that which helped resolve the stress before. There you get the self-medication loop of addiction. It gets worse. In active addiction, I like to say this, I don't like saying it, but it's the truth, the poor get poorer. If it wasn't bad enough that I needed self-medication, I can get myself into a vicious cycle of shame around my addiction. And what does that look like? This. In active addiction, let's say that I started off being vulnerable. In the examples that we had, I started off being vulnerable by being rejected by a family member or rejected by a job. And so I'm already coming in vulnerable and not feeling good about that. We've already made clear that in the presence of a threat to social acceptance, our cortisol goes up, our stress goes up. And now we've established the loop that gets created. If I can find something that will help elevate dopamine quickly, it will help reduce my sense of stress. And that which does the best job are addictive behaviors, particularly the substances. I'll give one example, is that methamphetamine elevates our typical baseline dopamine level 12 times its normal level. And so if I'm in a state of high anxiety and can take something that is 12 times my normal dopamine level, and that normal dopamine level has now been elevated up that high, and it effectively reduces my shame or stress to zero, you can see why I would resort to that in the presence of shame or stress. The problem with it, and this is where the vicious cycle comes in, is after I've engaged in addictive behavior, I expose myself to more shame or self-loathing, as well as judgment and rejection from others, because after all, I've engaged in addictive behavior. And so you've got yourself in a vicious cycle. Shame leads to addictive behavior, leads to more shame. What do we do about that? We reach for the addictive behavior, the addictive substance, which leads to more shame, and so on it goes. It's going down the rabbit hole of shame and stigma. Okay. What do we do to reverse this? What's to be done? How do I break this cycle of self-medicating shame, which leads to only more shame, which I need to self-medicate? What do I need to do? There's a lot that can be done, but I want to focus for the last portion of our time here today with a couple of thoughts and another exercise, okay? It's very important that we make a key distinction in talking about shame and its relevance. Now, why is shame relevant to addiction? Because the number one trigger for relapse is stress, and the number one stressor in terms of human emotions is shame. So if we can find some way to address shame in a way that's healing and helpful, we'll be taking a big bite out of our vulnerability to relapse. So here's the distinction that we're going to focus on for the next few minutes. I'd like to make a distinction between shame and guilt. Specifically, the way that we'll be talking about shame is that shame is toxic. We've already talked about the toxic nature of shame in terms of kicking up our stress levels, and that it's tied into a sense of failure, self-esteem, as well as being rejected. But we want to make a distinction between shame as toxic and what I refer to as rightful guilt. And that will make more sense if we break this down a bit. How do we make this distinction, Dr. Bob, between shame and guilt? Here's a suggestion. Guilt might be defined this way: I did or have done something bad. Shame, in contrast to that, is I am something bad. Notice that I picked the word something rather than someone, because my sense of it with shame is that shame actually moves us from being someone to something, just an it. Guilt, I did something bad. Shame, I am something bad. Now, why does this distinction matter? Let's talk a little bit about this in terms of the brain. Guilt, for what we've done, actually locates itself in the front part of our brain, referred to as the frontal cortex. The frontal cortex is the seat of our executive functioning, which is just to say we can make changes if something is operating in our frontal cortex. And in fact, our motivation to change, our motivation for caring for others, our motivation to act morally emanates out of the frontal cortex. And so the good news about guilt, it doesn't feel good, but the good news is that it motivates us to change. Let's take a look at how that contrasts with shame. Shame actually emanates from the middle part of our brain, right between our ears. This is referred to as the emotional center, or more technically, the limbic system in the brain. It's also very much connected to the reward circuitry that are intrinsic to addiction. Shame is a more primitive response in the brain. And in fact, shame doesn't come from the frontal cortex. It's a function of, look at the italicized comment there. Shame is a function of what's referred to technically as hypofrontality. What does the word hypo mean? Beneath, as in hypodermic, underneath the skin. Hypofrontal, it means beneath the frontal cortex. In essence, it means in the midbrain. And so shame is a midbrain phenomenon. It's very much related to three reflexes in the survival part of our brain. Those three reflexes, you'll be familiar with the first two and possibly with the third. The first two are the fight or flight reaction. Faced with threat, I'll either fight, I'll move towards and aggress, or I'll flee, I'll move away as quickly as I can. But there's a third component to the midbrain's response to threats to survival, and that third response is a freeze response. Ever heard the phrase playing possum? Ever seen a possum? Let's say that you live, well, many of you live in Idaho or in the Pacific Northwest. If a big bear comes upon a possum, what does the possum do? Does it fight? No, it doesn't stand a chance. Does it flee? No, it can't move fast enough. What does it do? A possum freezes. Now you'd think, what's the survival value of freezing in the midst of that kind of threat? Well, it turns out that the bear will think twice about killing and eating the possum. Why is that? Because if the possum is playing dead, the bear might not know how long the possum has been dead. And there's a risk of it getting infected and getting sick, maybe even dying. And so it's built into us as a species to freeze in the presence of certain kinds of threats. So shame is an emotional freeze response. Think of how you feel when you feel ashamed. The body will react in terms of feeling a feeling in your stomach or your chest, maybe your face, maybe you blush, maybe you sweat, maybe you feel pinpricks in your head, all of those things. I mean, because I experience all of those when I feel shame. I grew up in Texas where we talked about shame this way, where you just want to crawl into a hole. Maybe you're familiar with that phrase yourself. Shame makes me want to crawl into a hole. Shame, to use the earlier analogy, makes me want to play possum. Shame stops me in my tracks. Remember how we talked about that guilt motivates us to make change? Shame actually stops me in my tracks and prohibits me from making change. I've been doing some research this past week. It turns out that shame comes on board developmentally before guilt does. Shame is on board for us as individuals in the first year of our life, before we even have words. Guilt comes on in the second and third years of our life, where vocabulary begins to develop. And you can even think of why that's the case. Shame makes me bad, and it's more of a feeling than a concept. With guilt, I can talk about what I did. I can give words to what I did. There's an objectivity with guilt, is that I can look at myself in the situation more objectively and correct my behavior. Shame makes me bad, and I can't get outside of it. I can't get to an objective position with shame. I'm trapped in my subjective misery. And so you can even understand the logic of how it is that shame comes on board first. And also shame serves us developmentally, or in terms of survival, is that I need to get my early caregivers to take care of me. Otherwise, I will perish. And so it's absolutely essential that be highly motivating to me in terms of its unpleasantness. Psychology refers to it as negative reinforcement. I want to avoid at all costs something that feels so painful as shame does. So it does motivate us in that way. A quick question and then another exercise. The central treatment priority in working with addiction, as I understand it, now from a psychological perspective, is to correct what psychology calls the fundamental attribution error. Before you give up, before you get lost, I want you to think of, what does the word attribute mean? When we attribute something to somebody, what does that mean? Think of how you define that for yourself. That's all this is talking about. Psychology looks at how it is that many of us, under many circumstances, commit an error in how we attribute responsibility, both to ourselves and to others. When we mistake what somebody does for who they are, that's an example of the fundamental attribution error. And one of the problems in addiction, and I know this firsthand, and if you've dealt with addiction yourself, you will know this firsthand, is that the same attribution error can turn towards ourselves, and that goes like this. That's when I mistake what I've done, that is to engage in addictive behaviors, when I mistake what I have done for who I am. What's the problem with that? We've already established that shame paralyzes. Shame will kill us in terms of our addiction, because we cannot get out of the starting blocks with shame going on. If this is something about who I am as being broken or defective, why hope for any change? Whereas if addiction is something I have done, it opens up the possibility for me working on that which I've done and making changes so that I don't continue to do it, because after all, it's something I've done. It's not who I am. Just as shame paralyzes, I believe that the information that we're talking about today frees. I've seen this again and again with clients. As we begin to make this distinction between toxic shame on the one hand that paralyzes us, and rightful guilt on the other hand that motivates us, that actually frees us to make changes, it can make all the difference. So here's the journal exercise I next want you to engage in. Can you remember a time where what you did was mistaken for who you are? Can you remember a time for something that you did, and let's say that you did something that was hurtful to someone else, but that it was mistaken for who you are? So rather than you doing something bad or wrong or hurtful, what was attributed to you is that you are now seen as bad. You are now seen as hurtful. You are now seen as defective. Give a moment to that and jot down a thought, and I would invite you to share, if you will, with us. As we were sitting here together, I was reviewing how that went for me in my own addiction and even my own early recovery. It is ironic, and some of you will be able to relate to this, and I don't think I fully understood this before until I've actually experienced it from the inside, is that to be addicted or to have been addicted there were attributions made to me in terms of kind of once an addict, always an addict. You might as well equate that with once a loser, always a loser. But I found it ironic and surprising to me that now that I was in recovery, that actually had negative attributions made there as well. is that to be in recovery was to suggest accurately that I had been addicted. Hence the connection was, well, if you're in recovery, that means you were an addict, and once an addict, always an addict. And so there was a way that it didn't matter whether I was actively addicted or committed to recovery. There were attributions that were made, and it was very difficult for me not to do that towards myself. We talked about the fundamental attribution error, where it was very difficult for me not to commit the error or the mistake of attributing something that I had done, addictive behaviors, to something I am as Bob Weathers. Let's see, somebody, Joy commented here. My name is Joy, so it is assumed that I'm always happy, bubbly, and optimistic, like I have no other emotions or feelings. You make a really good point, Joy, is that these attributions can be negative in nature, and they can be positive in nature, and even this perhaps positively intended attribution. Your name is Joy, so that you must always be happy and bubbly. That ends up confining you then, and so it's an error of turning your name into who you are. We will say, I am Joy, I am Bob. The fact is that you are so much more than Joy, as I am so much more than Bob. And be careful about that, even with our names. So imagine if we substitute for the name Joy the word addict, and what that brings up for individuals, and how that can move into kind of a final diagnosis that's immovable. Thank you, Joy. Deborah, I'm going to read what you said here. Thanks, Joy, for your response. Deborah says, I really don't know why, but my father once said when I was going to have a baby, and I didn't want a girl because I didn't want to treat her like my mom treated me, my dad said, oh, little girls are great. Linda did this, and Linda used to do that. And I said, Dad, I was your little girl too. And my dad said, but Deborah was such a disappointment. I said, when? At 2, at 5, at 7. He said, well, Deborah always asked why. Wow. Thank you, Deborah. Appreciate you sharing. These things leave such deep wounds and scars, don't they? I tell you what, you saw where I paused. Dad said that Deborah was such a disappointment. That's really it, isn't it? When you get right down to it, you can, in fact, I talk about this with the clients that I work with. Any one of us can tell when a father or a mother, or for that matter, anybody, looks at us with eyes of disapproval, of disdain, of judgment, sometimes even of disgust. Words don't even have to be said. So to grow up where you end up being on the receiving end of that kind of rejection is so incredibly painful. And so, Deborah, I'm going to, first of all, I want to thank you again for what you shared. I'm going to work with that for just a second. Imagine, Deborah, or any of us that have shared, Joy, you're included, Angela, you've shared. Imagine what it's like if what's been laid down early on has left us questioning whether we're really worthy of love, whether we're really worthwhile in the world. Has left us feeling disappointed. And then imagine what happens as we reach adolescence and begin moving out in the world and have this template or blueprint inside, which is, I am disappointing. And I always felt that way with my dad or my mom or whoever had the most influence on me. And imagine what could happen if I could take a substance that altered that state of affairs, that altered that set of emotions, even temporarily, to where for a moment I could feel on top of the world, or maybe for a moment I could just feel numb and not feel disappointment. Can you see the vulnerability to addiction there? And then imagine what happens that once I medicate myself with whatever the substance is, and then begin to evoke further judgment and rejection, imagine the sinkhole that goes into, and now you're back into that vicious cycle we were talking about, where there's a tremendous amount of research to suggest that childhood neglect and trauma correlate with adult substance abuse and addiction. And then the painful irony is that once I become addicted, I only experience more rejection for what it is that I grew up living, which was being disappointing to my father. Let me read a couple more comments here, and then we're gonna wrap up in about 10 minutes. Give me just a moment. I'm going to read what Sarah shared. Thank you, Sarah. I work with people who are experiencing homelessness. I love your way of describing that. Thank you. You remember how earlier I talked about individuals seeking recovery from addiction? It's cumbersome to use that language, but any shorthand language is fraught with the difficulty that comes with turning somebody who's complicated. I'm experiencing homelessness into, now I've got a label. In fact, she goes on to say, somebody who's experiencing homelessness, and is definitely something that people feel shame about, saying, I am homeless creates an identity. There it is. I am homeless. I am an addict. I am a this. I am a that. My name is Joy. Creates an identity that people feel like they cannot escape. And that's the problem with this attribution error. That's the problem with shame, is that if it becomes something whom I am, there's nothing I can do to change whom I am. And that's become hopeless. There's no hope. In fact, Sarah, what you say in the last sentence is really key here. If we can somehow move to looking at this from as a situation, a temporary experience, as opposed to a permanent label or permanent way of being, we've effectively resolved the attribution error that we talked about earlier. Moving from being a comment about my character to about my circumstance. I can change circumstance, may be a bit more difficult to change how I'm fundamentally wired. I want to move on. Thank you, Sarah. I want to move on to Gabrielle's comment here. Here in Idaho, Black folks represent 2% of the population. In my department of work, I am the only Black person there. Therefore, anything new they find out about me is questioned to determine if it is a part of my Blackness or a part of me. Ultimately, I realize I'm sometimes viewed as Gabrielle and sometimes viewed as a Black person experiencing a very white place. Very, very sorry to hear that, Gabrielle. And you've just named it right there, is that anything new they find out about me is questioned to determine if it is a part of my Blackness. We talk a lot about this, Gabrielle, in the groups that I lead, about a self-fulfilling prophecy, is that anything that I do will help fulfill somebody's projection onto me. Somebody can project blame and assign all kinds of things to me because I'm an individual who's in recovery from addiction, and they can find something to confirm that, and it just winds itself into a tighter and tighter mess. Debbie says, I was placed in Head Start at 5. I lost my dad at 4. I was told I was bad for giggling at a puppy accident. Forgotten under the table until I was kicked by classmates eating lunch. These examples are heartbreaking. You know what the truth is, Debbie and Gabrielle and Sarah and all of us, Joy and Angela, is that all of us have felt like disappointments to somebody. All of us have felt judged by others. And if it's true what I shared earlier, do you remember the study that came out of Johns Hopkins that individuals who are suffering with addiction are at the very bottom of the barrel in terms of American society around diagnostic categories? Then you can imagine that what every one of us can relate to, whether I'm Black or a female or have this name or come from this background, or in this case, have an experience of addiction. All of us have an experience of what it's like to be marginalized, to be ostracized, and how wounding that is. And can you see the bind that creates? Is that when I ask clients, what's it like? Here's an example. I'll ask clients, I said, have any of you experienced being sincere about being in your own recovery, only to have people that really matter to you look at your behavior? Because early in recovery, behavior is typically very erratic, owing to what's referred to as post-acute withdrawal syndrome. Have you had somebody look at your behavior? Let's say that you're moody. Have look at your behavior and then attribute to you that you're just using and just a lousy, no good addict anyway. I'll ask that question, and over 2/3 of people will raise their hand immediately saying, yes, I have experienced that, where people that I thought were on my side and supporting me in recovery questioned it because I had a bad day, and now they assume that I relapse. Now, while it's understandable that could be the attribution, it's understandable that somebody could worry about their son or daughter relapsing. It's an extremely painful accusation when it turns into an accusation. And my next question to clients is, they'll say, and what have you done in the face of that? And then you know the answer to this. They'll say, well, I used. And why did they do that? Because the feelings that we've just documented, thank all of you for sharing. The feelings that we've just documented here that trace back across our entire lives, when those get evoked, is that we've got that trigger going on in the external environment accusing me now of using, and I feel awful about this, and I know how to feel better, and it's like trying to avoid the knee-jerk reflex to not relapse. There's no excuses in this, but what we are aiming for is understanding. Let me say a word about understanding as we wind down for today. I really appreciate you guys being involved. Thank you. It means a lot to me to have you engage with me. There is hope. There is hope here. First of all, if we can find some way back to guilt, which opens our hearts in place of shame, which closes our hearts. And many of you listening may be aware of this personally, and or be aware of it at least as a resource in your community. I'm going to talk about self-help support groups for just a moment. Self-help support groups, like I mentioned earlier, 12-step support groups being one example. I'll also mention smart recovery. I'm very active myself in refuge recovery, which is a mindfulness-based approach to recovery. What's in common with these self-help support groups around addiction and recovery is that they help move from shame to guilt. That is, you begin by identifying the problem. The problem is addiction, and then you externalize it. I am not my addiction. That is not who I am. I am Bob Weathers. You are Joy. You are Sarah. You are Deborah. You are Gabrielle. That's who we are. And if we have an issue, let's say if it's with addiction, let's start by talking about that as being something other than we are. In other words, externalize the problem means it's a problem that we need to fight, but it's not ourselves that we're fighting. To be more specific about this, in the self-help support groups that I've been involved in, including AA and refuge recovery, there's a tremendous amount of focus on taking daily inventory about how I'm doing in terms of acting morally towards others and towards myself. So what I'm doing is constantly trying to be aware of anything that I might miss. This is referred to as shadow work. And I'm in a group where I'm being actively encouraged to share my shadow, being encouraged to share my faults, my stumblings. In fact, it's expected of me, and the response is acceptance. We've been talking about being rejected, about being kicked by other people, by being kicked out. What would it be like to engage in a group of people that are there really to help? Their one commitment is for us to be honest, and they're there to support and accept us as we move towards increased healing. There is hope, and it's built right into these self-help support groups. I think it's built into the best of treatment of addiction is, from a psychological perspective, the common denominator is unshaming. I want to finish up by referring back to the first question that was asked by Angela, which is, are we going to talk about the spirituality that undergirds the healing of shame and stigma? I believe it's implicit in all that we've talked about, Angela, is that the hope is that we might find a basis for unshaming. Had we another half hour, maybe we can come back and spend time with this. I'd want to take us through a forgiveness exercise that allows for us to find forgiveness for others, as well as to ask for their forgiveness, and most essentially, to find a basis for forgiving ourselves. And I see that as every bit as much of a spiritual practice as I do a psychological reality. And I'm hoping that I might come back and discuss that. I want to mention, while I'm thinking of it as well, a future presentation that I would love to do here, and perhaps that would be a possibility, would be to talk about family resources. We've been talking about some of the wounds that we bear from families. There's a tremendous amount of resource in families at their best. And a second project I'm working on right now is a book entitled Plural Recovery. The fact is we need one another, whether it's family, those in self-help support groups, even what we're doing today. The fact that you all would be willing to share with me vulnerably what you've been through, and I hope that you've heard that from me as well, means that we're in this together and we do better in healing from shame. I love what the shame researcher Brené Brown talks about when she suggests that it's essential that we be vulnerable with one another to heal shame. Shame would move us into the corner. You remember how I said it makes me want to crawl into a hole? Sharing with you is crawling out of the hole, and that's the best that we can do to fight shame. If there are any final questions, let me suggest this. I would love for you to write me. You can contact me here at drbobweathers.com. You can also contact Emily or Anna, and they'll pass along questions you have. Very happy to correspond with you. If you go to my website, you'll see there's a contact me and just send me email. I really hope that this has been helpful to you in some way or another. Pass this along to your friends. I know that Anna is going to announce this, but this will be archived as well, and you can refer back to this and bring any comments or questions you have to me. Anna, it's over to you now. Thank you all.
Thank you, Dr. Weathers. That was amazing. I really enjoyed that presentation. We have a few viewers in our office, and I think that they really enjoyed it as well. Yeah. So thank you all for joining. In about an hour, there'll be a follow-up email that will be provided to you. There should be an evaluation. And also, yes, this will be an archive webinar on our website, which is www.empoweridaho.org. We have an upcoming webinar with Gabrielle Davis, who actually was attending. Hi, Gabrielle. On nicotine cessation and behavioral wellness. And we're very excited. That's in November. So I'm sending a link right now. You can subscribe to our newsletter if you would like to keep updated about similar awesome events, just like this one with Dr. Bob Weathers. We have a Facebook, just search Empower Idaho. All of our events are up there. Thank you so much. Again, this was great. Dr. Bob, we love you.
You're very welcome. Very happy to be with you. Somebody asked about my PowerPoint. If you'll write me, I'm very happy to send you a link to the PowerPoint. Very happy to share that with all of you. Thank you. Thanks, Anna. Thanks, Emily. Blessings to all that attended today. Really appreciate it. Take good care.
Bye. Thanks.